Today, I'm joined by a GP and aesthetic doctor. Alongside her private practice, she is passionate about women's health and she works in gynaecological hubs across the West Midlands. I cannot wait to hear from someone inside the NHS who can tell us all about her experience from the other side. Please welcome Dr Hazel Parkinson. Hi, thank you so much for coming on. It's lovely to have you here. So, we've introduced you both, you've almost like the two amazing careers and specialisms that you have, both as a GP, general practitioner, and then also in aesthetics as well, and helping women with so many different skin issues and body confidence and everything that you do. I would love to start with your trainings. I think it kind of sets up as a nice foundation for what you do now.
Yeah, absolutely. So, as you say, I am a GP and I qualified as a GP 18 years ago, which is showing my age somewhat.
I imagine that's gone quickly.
It has, and it goes quicker year by year, doesn't it?
Yeah.
But yeah, so I qualified as a GP 18 years ago, and as part of my GP training, I did 6 months in women's health, so obstetrics and gynaecology, and I really enjoyed that. And I think in my early days as a junior doctor, the two areas that I sort of really had the most interest was women's health and dermatology.
Yeah.
So I went on to do postgraduate diplomas in obstetrics and gynaecology, in sexual and reproductive health. I did letters of competence in fitting intrauterine devices and contraceptive implants.
Yeah.
And then when I was a GP, because I had all that under my belt, I very soon became the go-to women's health GP at the surgery.
Yeah.
And when you're there, you then learn more and more on the job.
Yeah.
And alongside that, as I say, I had this real passion for dermatology, which I did a postgraduate diploma in clinical dermatology in 2012, I think it was, at Queen Mary's University in London.
Yeah.
And after that, I've then gone on to do more menopause training, initially sort of foundation stuff, but now more advanced menopause training as well. And then, a few years ago, I think it was about 3 years ago, I was starting to feel close to burnout as an NHS GP.
Okay. I'm not surprised for doing it for that long.
Yeah, and I think the demands have got higher and higher and higher.
Yeah.
So I was feeling close to burnout and I needed something to change because I don't think I could have carried on for another 18 years. And so I quit my job as a salaried GP and I took a role in the NHS working as a community gynaecologist. And alongside that, I then trained up in aesthetics, which seemed like a nice sort of follow-on from my dermatology interest.
Yeah.
And that's where I created my private clinic, Dr Hazel Skin Solutions, which is an aesthetics and wellness clinic. And really, I can combine all my backgrounds of women's health, dermatology, and aesthetics all in that one clinic.
Yeah. It sounds very holistic in terms of, like you say, there's a lot of backgrounds there and a lot of specialisms and areas that you've studied and then practiced in that are all kind of coming into what you do now in your private clinic.
Absolutely.
So when you backed a few years ago, when you were doing obs and gynae, was it as a junior doctor? Was that in hospitals?
Yeah,
So you had
so back then we were called senior house officers. I think they'll now call them foundation year 2. But basically a junior doctor.
Yeah, and you were in hospital.
Absolutely, yes.
So you'd done medical school and you were doing the practical on the job.
Exactly, yeah. And we did, a nice balance of gynaecology and obstetrics, working on the labour ward and that side of things. So, yeah.
So tell me what it was like, because like you say, things are very, very different now.
Yes.
So from your experience, because obviously you've gone from being at the start of your career, being in those hospitals, doing those departments, all the way to then leaving and now doing what you do. What was it like then, and how did things progress and change as the years went on?
I think it's fair to say the NHS is really struggling now, isn't it?
Yeah.
And it's sad to see that. Certainly the difference I see in areas like A&E, when I worked in A&E again around the same time that I worked in obstetrics and gynaecology, seeing what we provided compared to what they provide now is very different. But I think, that ultimately stems from the fact that the NHS has been chronically underfunded for decades. You know, there was a while ago now, but Jeremy Hunt, I remember being a health minister, and, you know, he was quite openly talking about dismantling the NHS and privatising segments of it. And this was all well before COVID happened.
Yes.
So COVID didn't cause the collapse of the NHS, as, you know, the MPs will tell you. It just accelerated it.
Yeah.
And so I think what we're seeing now is that frontline staff, you know, doctors, nurses, all the patient-facing staff, they're working their absolute best, but in a completely broken system.
Yeah.
You know, the demands are just ridiculous. The bureaucracy is overwhelming, and the emotional toll is really, really high. And whether that be in hospital, whether that be in general practice, you know, that's what led to me feeling like I was close to burnout and feeling like something had to change. And I really feel for GPs and hospital doctors and nurses and everyone working in the current NHS, because sadly it is very broken.
Yeah. It feels a bit like Mission Impossible, or at least from an outside perspective, no experience in that whatsoever. So at least from an outsider, it looks like Mission Impossible by the sounds of it, all the different things you have to try and balance.
Absolutely, yeah. And without, I don't know, ridiculous amounts of money poured into it, I just don't know where we're going to go from here.
Yeah.
And so, you know, part of me sort of moving into the private sector was in the hope that I could provide something different, you know, something that maybe worked better, and, you know, allowed space for women to talk and feel supported and feel empowered without, you know, time constraints and all the red tape that comes with the NHS.
Yeah, and I think we've spoken before about that makes me think of what you told me about appointments. So just even something as simple as the amount of time you can sit with someone and talk to them, and how, like you say, that's very different from GP surgery or even NHS gynaecology to, like you say, private and running it in your own way, on your own time, with your own resources.
Absolutely. I sometimes book patients 2-hour appointments.
I mean, that's
you know,
that's just
if that's what I feel that they need, then absolutely. And that's wonderful. But part of the reason I love my gynae job is there are still time constraints, and I nearly always run over, but at least I have half an hour appointments as opposed to 10 minutes.
Yeah.
You can't really achieve much in 10 minutes, and you certainly can't be giving, you know, patient-centred holistic care at all in 10 minutes. It's what's the problem? Here's a quick fix. Out you go.
Yeah.
And if you do anything other than that, you're going to run late, which good GPs will do. But, you know, it's far from ideal.
I definitely want to come back to GPs and the experience for you as a GP within the surgery, and like we talk about running late and the implications of that and all those things. But just quickly, when we think about your experience doing the Women's House 6-month placement and then over the years and what you do now, I'd love to know whether you've seen a shift in attitudes towards female patients or women's health or conditions like that. Because 18 years ago,
oh my word, yes,
things I imagine were very different.
Yes,
but
absolutely.
Then in some ways, good and bad, maybe some things have changed and haven't changed.
Yeah, so on the one hand, as I say, I think the demands are higher and the funds are lower, and we're working in a broken system. But without a doubt, there's been a change. You know, back then there was a real, dare I say it, old boys network, particularly amongst the surgeons. But, you know, gynecologists are surgeons as well.
Yeah.
I remember an awful surgeon who asked me about what the signs, what are the 3 signs that a woman's got pelvic inflammatory disease, and I said, you know, a tender lower pelvic area, maybe a high fever, and maybe some discharge, you know.
Yeah.
And he was like, oh no, you're getting it all wrong. And he said, if they've got painted toenails, red underwear on, and I can't remember what the third one was, maybe it was pelvic pain, but I was just like, you know, I mean, to be able to say things like that.
Oh my God.
And be teaching that to people, it's horrific, isn't it? And, you know, that was not unheard of back then. I had a friend who was a trainee surgeon, so she was a junior doctor, but she was on her surgical rotation. She was also Asian and female. And one of her consultants said to her, you're the wrong sex and the wrong colour to be a surgeon. I mean,
oh my God.
How can people get away with things like that? She's now a consultant surgeon in Australia. She's doing very, very well. But funnily enough, she's left the country.
I'm not surprised.
So yeah, it's horrific, some of what was going on back then. But as I say, equally, that wasn't everyone. That wasn't everyone by any means. And there was lots of people working very, very hard. But yes, there was definitely a lot of male chauvinism and that sort of horrible old boys network, which totally put me off doing anything like surgery, and why I wanted to go into general practice, which was a bit more, you know, holistic even back then. But now, you know, I work in a women's health service where we're all GPs by background. We're all female, and we all deeply, deeply care about what we do. It's, you know, I'm absolutely privileged to work alongside some, incredible GPs with specialist interests in women's health. Who are absolute fountains of knowledge, but also really, really supportive and really, you know, wanting to delve deeper into everything. So yeah, I've learned so much from them in terms of, you know, that holistic approach and, you know, looking at things like people's lifestyle, their stress levels, their nutrition, you know, all of that factors in massively with a lot of women's health conditions. So it's good in some ways, but then as I say, the NHS side of things is not so good.
It's that, you know, it's such a contrast of even just kind of communities and the atmosphere, like you say, and it's the place you're working in now sounds fantastic, and it's helped a huge amount of people. Just quickly, you mentioned it's a good term of phrase actually, almost 18 years ago, and it was a boys' club, or kind of men mainly in those roles. Almost a two-part question. I've always wondered why there are so many men in gynaecology. Is it because it's fascination with the opposite sex? And then the other part,
that's a good question.
of do you think, obviously things will change over decades and new generations coming up into the service and things, but do you think that has trickled down?
I think they're already changing a bit. I think so. And I think that comes from a place where women want to see women for their gynae issues, don't they? As I say, in my service, we're all women, but I realise there are still a lot of sort of consultant gynaecologists who are male. Why is that? I don't know. I think a lot of them maybe were wanting to be surgeons, but couldn't get into general surgery, and so went down the gynae route. Right, okay, maybe. Okay. But I that's just me guessing a little bit. But having said that, I've got a male friend who's a consultant gynaecologist, and you know he was meant to be a consultant gynaecologist. He's absolutely wonderful. You know, his bedside manner and the way he cares about women and things like that. So I don't want to say all men are bad or anything like that. No, definitely not.
I mean, I've only ever seen male gynecologists, right? Yes, but the consultant, actually the endometriosis specialist consultant who I'm now under, and hopefully will be for a very long time, is absolutely phenomenal. Like he's such an incredible man. So like you say, there are on both sides, both genders, some people that you just know were meant to go into that profession because they are so good at what they do, and they're so, like you say, compassionate and lovely towards their patients, which is amazing. So when you were a GP, when you were in the surgery full time, how was that for you as a GP, obviously as a profession, but also as Hazel, as a woman, and then as a mum, and how did that impact you working in that?
Yeah, so I would have good days and I would have bad days. It is a you know, it's a fairly fast-paced job.
Okay.
In so much as you've got your 10 minutes, and I notoriously was always running late, but I think that's because I was, you know, trying to give the best care that I could to people. But it wasn't just, you know, you'd have a morning surgery with 17 patients and 10-minute appointments, and then you'd have your afternoon surgery, which was similar. You'd have maybe a 3 or 4 hour lunch break. It wasn't a lunch break. It was time to do all your admin, your bloods, your letters, do your home visits, which, you know, sometimes you might have several home visits to do. And so you didn't really get a lunch break. You had your lunch in the car whilst you were driving to a home visit or whilst looking at blood results or whatever. So it was really kind of non-stop. And as I say, good days and bad days. So the good days would be, you know, the days where maybe you felt like you'd made a real difference to, for instance, a palliative patient or, you know, something like that. And the bad days would be the days where you just felt like you were drowning, and you know, you how can I sort of cope with this level of work? And so what happened over the years was I reduced my hours. You know, I started off as a full-time GP, and you know, then went down to 8 sessions to 7 sessions, 7 sessions to 6 sessions to 5. By the time I left, I think I was only doing 4 sessions a week, or maybe 5. But yeah, I had at some point only done 2 days a week. But the days that I wasn't in, I was spending the entire time on my work laptop doing admin for my job, just not being paid for it. So it was, that's how much admin that, you know, there is in terms of all the blood results, all the letters from the hospital. And again, with the NHS being struggling, we're finding that secondary care are pushing more onto the GP. So in the past, you know, it may be that a patient would have been seen in A&E. In fact, I can tell you a story. My mum went to A&E recently, having gone into a heart arrhythmia and heart failure. And they rate controlled her, and then were basically going to send her out. And I was there saying, hello, why are you not putting her on a blood thinner? She's at increased risk of a stroke. Why are you not organising an echocardiogram for her? Because she's got heart failure. We need to get this assessed. Why has she not been offered a cardiology follow-up for this? And they said, oh, we're going to write to the GP and ask them to do it. Which is not, I mean, you're saying, oh, but that's what they do now. Like, this is what happens. You know, so there's this sort of transfer of care. And I'm sure it's because they're swamped. It's not, you know, it's not their fault. But equally, you can't expect the GPs to do everything and not to do it in a timely fashion.
You're not suggesting that anyone's lazy or just can't be bothered or anything like that at all.
Absolutely not.
But
everyone is drowning in this system.
But from a layman's point of view, the reason, you know, that reaction that I had was the fact that I think naively, when you're not in the system, you maybe make assumptions that almost like maybe some levels of conditions or, you know, areas of speciality like gynae or, you know, maybe like leg pain or knee pain or whatever it might be, you think, okay, well, it's not like an emergency or urgent. So yeah, maybe they do push it to GPs. But my shock was thinking heart failure. Like, it can't get more urgent or serious or kind of life-threatening than that.
Had my mum had a stroke because she was in atrial fibrillation and not on a blood thinner, you know, what's going to happen there? You know, it's more impact on the NHS, isn't it? So, and had she not had a GP in her corner, how long would it have taken from the letter to get from A&E to the doctor, sit in the doctor's inbox for a few days, then to action it? You know, we could be talking weeks where she's potentially at risk. And she thinks, oh, A&E have sorted me out, everything's fine, because she's an elderly woman, and that's the, you know. And so it's that whole thing of, if you haven't got people there fighting your corner for you, it is just a, you know, as I say, a bit broken. Yeah. And no, you're right. And I'm so sorry that your mum went through that, because I can't even imagine how difficult that is personally for someone you love to go through that. But that is an incredibly powerful story to, like you say, demonstrate that point exactly. So
Similar but very different, because we know how amazing these hubs are, and I want to talk about them because the work they do makes such a huge difference. And I actually know women and have referred women to go and use these hubs, and they've come back with some fantastic stories about how
wonderful.
they feel seen and heard, and things have actually happened for them. So tell me about what the hubs are in terms of how they kind of assist the NHS or that GP kind of circuit, and what you guys do.
So locally in South Warwickshire, I think the waiting times to see secondary care gynaecology, so that's gynaecologists at the hospital, are about 2 years. And so the primary care gynaecology service was set up to reduce those waiting times, because it's completely unacceptable for women to be suffering that long without any sort of, support or help. And so the service was set up, and the idea is that we take the load off secondary care. We can do a lot of what is referred into secondary care. What we can't do is the major surgery. We are GPs with specialist interests in women's health. We're not surgeons. But even if we've got, a patient who's awaiting surgery, let's say they've got quite advanced endometriosis and they've been told that they need surgery for that, there's still a lot that we can do from a medical point of view and from a supporting point of view. So that's really, where we are. And I think we're also in a really great position to help with menopause care, which again, it's been sort of pushed onto the GPs, and not all GPs are really trained in it, and they certainly don't have the time to provide decent menopause care. And not everyone can afford private menopause care. So again, we can help with particularly the more complex menopause care as well. So that's basically the service in a nutshell. We've got multiple hubs, as I say, in initially it was sort of South Warwickshire, then Coventry and Rugby, and they're now up in North Warwickshire. So we've got one in Nuneaton. I'm trying to remember where the new ones are. But yeah, there's quite a few now. So
and it sounds like, just obviously girls and women listening, this could be incredibly helpful, because they might have, and before you told me, I had no idea this service existed. So we're talking about women and girls of all ages that this service can help and be applicable for.
Yeah, absolutely. I think you might need to be 16 plus. I don't think I've seen anyone younger than 16, but I've definitely seen a 16-year-old in the service. We'll have to check on ages.
But generally speaking, a very wide age range.
Absolutely. So we see, 16-year-olds with their heavy periods and their dysmenorrhea, their painful periods, which may or may not result, may end up being, something like endometriosis. And we see right up to our elderly ladies who maybe have pelvic organ prolapse and things like that. So absolutely, we see a full range other than proper paediatrics.
Yes. And you mentioned earlier about those different length of appointments as well, which make a huge difference. So you've got a bit of flexibility with that then, about how long you can potentially see ladies for. Kind
so,
of.
with new patient appointments and face-to-face appointments, we have half an hour, unless we need a translator, in which case we'll get an extra 10 minutes. With our telephone appointments in general, we should get half an hour for the first appointment, and then we tend to get 20 minutes for follow-up appointments. But if I have a lady who, for instance, I've had that first appointment for half an hour, and I know in her follow-up I'm going to need longer, I will add a little note begging for it to be a half an hour appointment. And normally they'll be okay with that. Obviously, if I did that with every single patient, then the powers that be would be like, and every now and then I'll get a new patient that is booked into a 10-minute appointment, and I'm like, why was that done? And I get very irritated. But I do find with the telephone appointments, because we're having to take a lot of history and sometimes unravel a lot of, dare I say, even trauma from previous experience or lack of input that they've had. Often, pretty much always, I will run over with my clinics, because we've got to gain that trust and everything again, and that can sometimes take a long time.
Yeah, absolutely. And you're totally correct. The whole thing around rapport and relationship building, because it is a relationship building, right? Like,
absolutely.
you're two complete strangers, And hopefully you need to get to a point where they can tell you everything and anything that's going on, normally of which is very intimate, and sometimes they feel it can be very difficult talking about.
Yeah, absolutely. And as I say, it's that often they'll come in with the barriers right up because of their previous experiences.
Yeah.
And so, yeah, it's just working with that and letting them know that it is a safe space.
Yeah. Living in agonising pain is one of the hardest parts of living with endometriosis. Every single morning, I would wake up with stabbing, twisting, throbbing pain all over my entire body. And the only way I could survive was by taking painkillers all day, every day. If you told me over 10 years ago that natural pain relief would work better than drugs, I'd have thought you were crazy. But then I found BU's pain relief patches. I've had the pleasure of working with the sibling co-founder, Hemang and crew, and I trust them. I trust them to do right by me. I trust them to do right by you. I trust them to do right by all of us. So, if your endometriosis pain is out of control or your periods are ruining your social life, then use discount Alexandra 10 for 10% off BU's products. Yes, you did hear me correctly. That is 10% across all their products. Go and have a look. What's the harm? You can also head to the show's description notes for all the information and all the clickable links. I'm so glad that we could just highlight it again, because again, if you're based obviously in South Warwickshire and you talked about it going to North Warwickshire a little bit as well, it's absolutely worth looking into, and it's the GP that ladies would go and
so if you are based pretty much in Warwickshire, Coventry, Rugby, then you can go to your GP and you can basically be asked to refer to the community gynaecology service, or the primary care gynaecology service is what we're officially known as. Waiting times, I believe they've gone up a little bit. So they used to be about 6 weeks, and I think now they're more like 8 to 10 weeks. But that's a whole lot better than 24 months.
I was about to say, compared to 2 years, that's no comparison, is it? I know if I was back in that position, 10 years ago, I absolutely know which one that I would go for.
And even if you feel, or even if you're on the waiting list for secondary care because you know, or you've been told that you need surgery, don't feel that there aren't other things that can't be done. So, you can still ask for that, and you can still be referred to the two places.
Yeah, and I was about to say, you won't be kind of disqualified or almost penalised for looking at the primary gynecology service.
Absolutely not. No.
Amazing. Okay, wow. Let's divert slightly onto skin and aesthetics.
Yeah.
Because a lot of the women that suffer with women's health conditions that we've touched on a little bit, so things like PCOS, endometriosis, adenomyosis, fibroids, PMDD, and many others. Yeah. I know that I had serious skin issues, and I really struggled for such a long time with my skin. Yeah. So I'd love to dive into what kind of issues we can see coming up with women with those conditions potentially.
Absolutely. I guess in that whole age range, the sort of common skin conditions that we see are acne, particularly sort of hormonal acne. We also see sort of hormonal pigmentation problems such as melasma. We can see breakouts related to either stopping the combined pill or starting the progesterone only pill, and also seeing quite a lot of sort of more inflammatory skin conditions, things like perioral dermatitis. We may find that their skin is a bit more reactive and a bit more sensitive, or we may find that happens because people are overusing or inappropriately using active ingredients, sometimes due to social media influence and not proper guidance. But certainly, acne, for instance, I mean, that's a really common one. It's multifactorial. Hormonal acne, which often affects sort of around the lower face and the jawline, is really common in women, but particularly women with polycystic ovarian syndrome, where there is this sort of androgen excess, and that sort of drives the process. And then with conditions like endometriosis, we see, more sort of inflammatory conditions as well. There is an association between endometriosis and psoriasis. So both of these conditions are conditions of immune dysregulation. And so if you have psoriasis, you're more likely to have endometriosis, and vice versa.
Wow, okay.
We also see a lot more allergic type conditions with endometriosis.
Yeah.
So endometrial deposits have mast cells in them. Mast cells produce histamine, and histamine is involved in allergy. So urticarial rashes, which are sort of rashes where you get these wheals, a bit like nettle stings that can come up.
Okay.
We can see increase in that with endometriosis, atopic eczema, and allergic dermatitis as well. And then you have slightly rarer skin conditions such as cutaneous endometriosis, which is where you can get endometrial deposits actually on the skin, more commonly at sort of surgical sites, where they'll get lumps and sort of redness and inflammation at the site, which will, flare up at the time of their period and things like that.
Yeah.
So lots of skin conditions. What I would say is that the skin really is a barometer of your internal health and what's going on. We can see flare-ups, for instance, when people stop the combined pill, particularly if they're on a pill which contains anti-androgenic progestins such as drospiridone, which that inhibits sebum production and oil. And so when they stop it, you get this rebound increase in sebum and oil, which can lead to acne and things.
So that's why when you come off it, it feels like almost, I remember that, your face almost feels like it blows up into just like constant spotting and acne.
Absolutely.
And it just kind of comes out of nowhere. So that's why that is.
Yeah,
Oh, okay.
Absolutely. And that can also happen if you go onto progesterone-only pills or, the progesterone contraceptive injection or the implant, that can also sort of drive that process as well. And I touched on earlier about perioral dermatitis, seeing a huge rise in this. So this is a skin condition where you get these little red lumps, often around the perioral area. You might get them around the corners of the nose, but around that sort of area. It's most commonly due to overuse of active ingredients. So that can be overuse of retinoids, vitamin C. We used to see it a lot with just people who were using steroids on their skin, and it basically impairs their skin barrier and leads to this irritation and inflammation. And the only way of treating it is just to stop using pretty much everything on your skin.
Right. Okay.
So, other than, I would always recommend people use, a non-comedogenic SPF. But other than that, it's pretty much just wash your face with a gentle cleanser or even just water, and don't use any other, including cosmetics, and it will then clear. But for a lot of women, that's quite extreme. Certainly seeing a rise in that as well. And then, you have to remember about the impact of stress and sleep deprivation on women who, this time in life, and particularly if they've got women's health problems, they're going to be more stressed. And that, shows up on the skin with worsening acne, with dull skin. The effects of cortisol, basically, it increases your sebum production, it increases inflammation, and so all your inflammatory skin disorders, and it also causes a bit more water retention, so your skin can look a bit puffy and things like that. So looking at sleep hygiene and things that we can do just to, help the nervous system can be really, really helpful, as can looking at nutrition.
Yes, I was about to say, because what you said before, someone described it to me once as almost your skin is almost a mirror to what's going on inside. It's almost like a huge communication.
Absolutely. And, when I was at med school, I was taught that acne wasn't related to what you eat, because that's what we were taught 18 years ago. But now, we know that ultra processed diet, lots of sugar, whey protein, all these things, dairy, blah, 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 it can all trigger acne. So I think it's really important to look at nutrition whenever you're looking at any skin condition, and particularly with some of the women's health conditions as well. So, for instance, as I say, I've already said, cut out ultra-processed food, reduce your sugar, and for some people, they may need to reduce dairy because that can be inflammatory. I always recommend having a high protein diet with healthy fats, high fibre, and lots of antioxidants in there, which can help with inflammation. If you've got something like polycystic ovarian syndrome, it's even more important that you stick to a low glycemic index diet, because
so that's
we know
about blood sugar, isn't it?
Yeah, so low glycemic. So all foods have a glycemic index, and it's about basically how either sugary they are or whether they're broken down into sugar. So, for instance, white bread and pasta is broken down into refined carbohydrates or sugar, whereas brown wholemeal bread and pasta less so. So the white bread and pasta will have a higher glycemic index than the brown. That's just a simple example. But yeah, low glycemic index diet, very important for people with PCOS, and for many women, not all, but many women with endometriosis, they will benefit from cutting out gluten and cutting out dairy. And if you're going to go down that route, then you need to give it a really good 8-week trial to see whether it does make a difference. But again, these things can be inflammatory and can just aggravate the endometriosis and make it worse. And your skin.
The two are so connected, aren't they?
Absolutely.
Internal and then your skin. And actually, you touched on it before, so I want to go into it because I think the use of social media, the incredible marketing campaigns and branding and making things look pretty and shiny. And actually, my other half is actually a sucker for this. I've had to really try and teach him. He is a sucker for nice, shiny marketing on any kind of facial grooming products that when you look at the packet, you think, oh my God, what on earth is in this? So it's very easy, I think, especially for young teenage girls when they start wanting to look into skin and makeup and things, to just chuck everything, like the kitchen sink, at their face.
And move from one trend to another really rapidly rather than having any sort of consistency, which again is not going to help. So yeah, in an ideal world, everyone should come and see someone like me, whereby you can actually put a proper plan in place.
Yes.
In terms of a bespoke skincare, which you can then be consistent with, and it is consistency over complexity.
Okay.
But yeah, you're right. You know, these absolutely unrealistic beauty standards, it absolutely drives skin anxiety. So even young girls who have good skin, it's not perfect. Therefore, you know, they're then doing things which potentially are going to make it a whole lot worse.
Yeah, I remember seeing this trend on TikTok. I remember looking at it thinking like, oh God, this is just going to make so many people feel insecure about their skin. It's something like the glossy mirror skin, or something like where people have this like shine over their face.
What's it called? The glass skin, I think it is. The glass skin facial, which absolutely, I mean, what's happened there? Who knows what they've done in terms of facial, but what they've finished it off with is just sticking a load of oil on their face and getting good lighting and taking a picture. I mean, it's called glass skin facial, isn't it? It's nonsense, absolute nonsense.
But then,
and
like
also, who wants to look like that? Because actually, if you walked around with greasy skin like that, it'd be horrible, wouldn't it?
I wouldn't even like the feeling of it.
Yes.
Like even just, it's like when I remember being a kid, even when you find sun cream, and I used to hate that greasy feeling of sun cream, like even just being on my skin on holiday, let alone pouring oil over my face. No, that wouldn't be nice at all. So, do you have any tips or just kind of good things to remember when we're thinking about maybe our skincare routine and regime, or all the products that you can get out there? Obviously, you say ideally go and see someone like yourself who actually knows what they're talking about.
I mean, in an ideal world, if you've got a skincare complaint, you need a correct diagnosis, don't you?
Yeah.
So start with getting the diagnosis right. And that starts with some investigations. So if you're able to, have some blood tests, have a hormonal workup, particularly, you know, if it's things like acne, because you could have underlying PCOS. So get the investigations done. Then once you've got a diagnosis, if you've got a diagnosis, you, as I say, you want to be looking at consistency over complexity, evidence-based skincare over trends being pushed by an influencer. Yes, I mean, for each skin complaint, whether that be pigmentation, whether that be acne, perioral dermatitis, there is a sort of route that we will go down. But in an ideal world, that also needs to be tailored to your skin.
Yes.
So, for instance, if you have pretty resilient skin with a, good barrier function, but you've got acne, we can probably hit it quite a bit harder with topicals than if you've got an impaired barrier, sensitive skin and acne.
Yeah.
So, it has to be really kind of bespoke to the individual. But I would say get expert help, and most GPs can help with this sort of thing.
Yeah.
And if you're not getting the help from the GP, then you can be asked to be referred to a dermatologist.
Yeah.
Or if you're able to, you can see someone privately. But if you're seeing someone privately, don't see an advanced aesthetic practitioner who is a beautician or a hairdresser by background.
Right.
Go and see someone with medical background, ideally dermatology medical background, who actually knows what they're talking about and isn't just going to sell you whatever skincare to make some money.
Yeah, let's touch on that, because obviously aesthetics is another area that you specialise in.
Yeah.
So we're talking about injectables and things like that.
Yes.
And there's been a lot of talk recently, hasn't there, about making that safer.
Good.
Yeah.
Thank God. Yeah. So, I mean, the aesthetics, and I hate using the word industry, I like to call it the field of medical aesthetics, but it is, unfortunately, the aesthetics industry is just completely unregulated in the UK, but particularly in England. So it's just like the Wild West out there, and you don't need to have any formal training to be injecting, for instance, dermal fillers.
Oh my word.
You could watch a YouTube video on injecting dermal fillers, or do your fillers from Filler Direct, and start injecting people in your dirty garage without any insurance, any formal training, and that is legal in the UK.
Oh my God.
So as you can see, there's a bit of a problem here.
And it really is that easy.
It really is that bad.
Oh my word.
There is, as I say, there's certain areas, for instance, injections of botulinum toxin, that's a prescription only medication, so it should be got on prescription. But again, beauticians were getting this from maybe nurses or doctors who were willing to prescribe it to them. There's been a bit of a hoo-ha recently because BAMAN, who's the British Association of Medical Aesthetic Nurses, have said that nurses must do a face-to-face consultation if they're going to be prescribing prescription only medication, which is what the British College of Aesthetic Medicine, who regulate the doctors and dentists and things, have been saying anyway. But that's caused a lot of these lay injectors to get their knickers in a twist, because it's going to be really difficult for them to get that. But yeah, I mean, the bottom line is, my personal feeling is that yes, you should have a medical background to be doing this. That's not to say there aren't probably some very good advanced aesthetic practitioners who have been around for a long time and know what they're doing and work very ethically. But as a bare minimum, we need to have a certain level of training.
Yeah.
We need for clinics to be at a certain standard, in terms of health and infection control and that side of things.
Yeah.
And there is none of that. And sadly, there's been deaths and all sorts. Yeah.
And for something that I think, especially, I mean, I don't know, maybe I live under a rock, but I think probably my generation and younger, it's definitely a lot more popular than I think I remember when probably I was that age of talking about it. It's a lot more, social media is a big part of that. It's a very open conversation, isn't it? And a lot of people want to do that.
Yeah, absolutely.
But like you say, it brings a lot of risks when it just becomes a Wild West and anyone can just do that. So if someone wants to explore aesthetics and they want to make sure they're being safe and looking after themselves, what do they need to look for?
So, as I say, I would recommend going to a medical practitioner, and you will find that they should be under a governing body. So, for instance, doctors, it's the GMC, the General Medical Council. For dentists, it's the General GDC, the General Dental Council. It's the NMC for nurses. And so they should have that governing body, which they are accountable. So should anything go wrong, they're accountable for that. So that's number one. Number 2 is, making sure that they have valid insurance to be carrying out these procedures. Number 3 is, finding out what their experience is and how long they've been doing injectables for. And if anyone's cagey about this sort of information, red flag, they should be open, and they should also be, able to show you some before and afters. Now, I have real problems with my social media trying to get before and afters because people don't want their before and afters shown to people.
No.
But if you've done enough work, you'll be able to get some, and you should be able to show, some, and, not botch jobs and things like that. So that's the sort of things that you really, as a bare minimum, need to be looking at. Also, ask about what products that they're using. So few people ask me what botulinum toxin I use, what brand of filler I use.
Oh, wow.
I will tell them because I want to tell them.
Yeah.
But people don't ask that information. Wow. And as happened in the northeast of England, did you hear about this? I think it's now 32 people were hospitalised with suspected botulism as a result of a beautician getting some knockoff, not CE marked botulinum toxin from Korea, which has ended up hospitalising people. So find out. I mean, if you're having something injected into your face, do you not want to know exactly what that is and exactly what the risks are associated with it? Yeah. It's
I think that part of the conversation is missing quite a lot, because I've got some friends that have explored that and have had that done. Some have, some haven't, at different stages, and kind of family connections and things. I've tried different things, and I think that is a big part of the conversation that's missing, in terms of they want to get it done for whatever reason that is right for them and it's their choice and their body. But the risk conversation, or maybe just the more technical kind of scientific, less exciting quotation mark part of the conversation maybe isn't had as much. But you're right, it's so important to know what you're doing and what you're getting yourself into.
It really is it absolutely baffles me. I will talk patients through the consent form. I will talk about every single risk associated with it, but equally my booking system, sometimes if someone books in for dermal filler, we'll send them the consent form. Sometimes they've signed it, and I'm like, have they even read this? Do they understand what a granuloma is? Do they it's like I haven't explained it to them. So it just baffles me that people can just look at a consent form and sign it without even really understanding what they're signing, particularly with something so important like your face.
Yeah, absolutely. So as we kind of come towards the end, I'm thinking about, obviously, like you say, a massive thing that I've definitely learned that's so clear from our conversation is your skin, like everything, is unique to you. And that bespoke plan and going to someone, because actually I could never untrained look at my own skin and be like, is my skin barrier really good, or is this working, or is this impaired, without the knowledge. So that's a key message for me. And I'm thinking about any other good messages. Like, I've heard a lot of things around everyone should be wearing SPF every single day of the year regardless of the month. Is that true?
Absolutely. Absolutely.
So that's a lesson for everyone.
So I mean, I make my money from people who want anti-aging effects, and without a doubt, the best anti-aging cream out there is a good SPF.
Okay.
So, 90% of aging that we see on the face is due to photo damage.
Okay.
So it helps with anti-aging. Collagen is key, and and UV light basically damages your collagen. So absolutely you want it for that, but also you want it for other more serious health benefits, the risks of skin cancers and things like that. I sadly have had a friend die of a melanoma. It's really important to be wearing SPF every day. For anti-aging, for, your fine lines and wrinkles, but also, for your overall skin health, to reduce your risk of not only melanomas, but non-melanoma skin cancers as well, which are also associated with UV damage.
Yeah, and that's men and women.
Absolutely.
I'm
absolutely.
So glad. I cannot wait to go
And also not just your face. It's all exposed skin. And I'm guilty of this, you know. For years, I used to just put SPF on my face. And for years before that, I didn't use SPF at all when I was, you know, a sort of teenager in early 20s. So, you know, we just didn't have the education back then. But you'll see it in you know, women maybe in their 40s and 50s. Their skin in their face looks lovely, but then their neck and the backs of their hands is all looking really sort of wrinkly. And that's just due to collagen damage and UV damage.
I'm so glad you said that. I can't wait to go home and tell Charlie that he has to wear sun cream like I told him to every single day of the year.
And the thing is, there's so many good SPFs out there as well.
Yeah.
So, you know, I think historically people are like, oh, but it's greasy and I can't put it on under makeup, or it makes my acne worse or whatever. You know, you can find the perfect SPF for you. And I love them.
Amazing. Well, that's a perfect piece. That's such an easy piece of advice as well.
Yes.
So obviously the more complex layers of go to someone that has the medical knowledge, the specialism, everything we've covered. But even if you're not in a position or wanting to do that or needing to do that because you haven't got any issues, that's just a good lesson for everyone to hold on to, which is amazing. Okay, as we come to an end, one thing I'd love to ask you, because you have so many areas that you've got such a wealth of experience and expertise in, just to go back to what we talked about earlier for a second, and women's health, from your experience as a GP and working in the hub now and just being in that world of the NHS, what would you like to see moving forward, of things to improve or continue, or like any lessons that have been learned that are working really well and things to continue, or things that need to get better and change?
Within the NHS, what needs to get better?
Women's health. So it can include the NHS, but women's health probably.
So, yeah, a few things. I think we need better joint up care. Okay. It's not very joint up. And as I say, on the one hand, I've said it's fine to have someone referred to the secondary care, gynaecology, and also referred to us. But sometimes we find that they're also been referred to another community gynaecologist. And again, it's the GP just trying to find, you know, a solution. But that it's all very disjointed and we don't necessarily communicate well together. So I think better joint up care is absolutely needed. We somehow need to get a lot more funding going into women's health and a lot more research going into women's health. You know, conditions like polycystic ovarian syndrome, endometriosis, menopause care, they've been historically not researched and not funded. And these aren't niche areas, are they? They affect millions of women.
So many women.
And, you know, therefore need that input. So, there is hopefully a movement towards that, I think, and I think with that will come increased knowledge, because we're learning all the time about these conditions. So lots more to learn, better joint up care. And then I think for patients, it's really just to tell you to advocate for yourself, come prepared, you know, come with your list of questions, and don't feel that you can't ask them if you don't get the answer that you're looking for. Keep pushing, you know, potentially get asked to be referred or see someone else within the same service if you're not happy with how things are panning out, because you have to be your own advocate as well. Yeah,
and I think that's sometimes quite hard for people to swallow, but I completely agree with you. Anyone that I speak to, obviously you want the NHS to advocate for you as well and work for you and with you, and you know, not have to have battles and fights. But unfortunately, the reality is, because of the way the system and how broken it is, to what you've spoken about, hopefully not as many, but still some attitudes. And unfortunately, there's lots of stories of a lot of traumatic incidents for women. But with all of that combined, the good and the bad, you have to make sure that you're educated and you're prepared, like you say, and you are as informed as you can be about your own body and what you're experiencing.
Absolutely. And, you know, doctors are human too. And sometimes we might make mistakes, or sometimes we might overlook or, you know, not think of something. So, you know, you doing your bit too can really help us.
Yeah, definitely. And I didn't ask you before, just because you've touched on it, the joint up care, that communication.
Yes.
You mentioned the word bureaucracy before.
Yes.
Is that an element of it when you talk about that? Is it like technical systems? Because we've had a lot about how like old the technical systems are and things like that.
I mean, I'm not involved
No.
in all the service planning and that
Yeah.
side of things. So I don't really understand why one area would have 2 community gynaecology services. I don't understand what's going on there.
Yeah.
But no, I think it's, when I say the sort of communication, it's more between, we don't see much communication back, for instance, from secondary care. I feel like there's scope there. We've had some wonderful consultants from secondary care come and do training with us, but I feel like there needs to be more of that. There needs to be more of the sort of integration so that we're talking to each other.
Yeah.
And wouldn't it be wonderful if we could maybe have some multidisciplinary team meetings where we actually got to speak to secondary care as well? Because one of the questions I get asked quite a lot is there nothing you can do to expedite my appointment with secondary care? Like, you've done everything you can and you've said that I need surgery and you know, and I'm like, no, I can't. There's nothing I can do. But it would be nice to have that communication, you know, where we're not going to use it all the time, but in people who are absolutely in dire need of it, do get that.
Yeah, it feels like it would be a lovely kind of joining together of 2 worlds that could just amalgamate and just have that smooth transition back and forth.
Yes.
Could make a huge difference.
Wouldn't it be wonderful in this ideal world?
We can dream exactly. And keep hoping. Dr. Hazel, you've been amazing.
Oh, thank you very much. And thank you so much for having me.
No,
it's been an absolute pleasure.
It's been a pleasure for me, and I have learned so much, both, in all the areas that you've worked and got so much expertise in, so thank you.
Thank you very much.
I loved our girl chat this week. Thank you so much for listening. If you enjoyed today's episode, then don't forget to hit the follow button wherever you're listening. To find out more about us or today's guest, then head to the show notes. Until next time, I'm Alexandra, and remember, it's not just a period.